My name is Kotaro Waki and I'm currently working as a gastroenterologist at Kumamoto University Hospital in Kumamoto, Japan. I'm the first author of this paper. On behalf of my co-authors, I'd like to thank the editorial team of GIE for the opportunity to present our article entitled Long-Term Outcomes After Endoscopic Resection for Late Elderly Patients with Early Gastric Cancer. This study was conducted at the Osaka International Cancer Institute. I'd like to start by acknowledging the hard work of my co-authors, without which this clinical research wouldn't have been possible. First, I'll explain why we conducted this study. As you know, with the population aging, the number of elderly patients with gastric cancer is increasing, especially in Japan. For early gastric cancer, EGC, endoscopic resection, ER, plays an important role in preventing gastric cancer mortality with less invasiveness than surgical operation. Although some reports showed favorable long-term outcomes after ER, even in elderly patients, few reports have examined whether ER improves life expectancy in late elderly patients. Furthermore, in clinical practice, it is difficult to decide whether to perform ER in late elderly patients because there are various factors which should be considered, such as the patient's background, region malignancy, the desire of patient and their family, the risk of adverse events, and medical and economic perspectives. So we conducted a single-center retrospective study to clarify the indication for ER in late elderly patients with EGC in terms of life expectancy. We also analyzed prognostic factors to identify patients who are suitable to undergo ER. Patients aged over 75 years who underwent ER for EGC at our institution from January 2007 to December 2012 were enrolled. Clinical data, including ECOG-PS and Prognostic Nutrition Index (PNI), were collected at the time of treatment. Overall survival was the main outcome measure, and we estimated 5-year net survival after ER. Net survival was the cumulative probability of surviving up to an arbitrary time, since cohort entry, after adjusting for other causes of death in the general population. 400 consecutive patients were enrolled. The mean age was 79.3 years. The 5-year follow-up rate and median follow-up period were 89.0% and 5.6 years, respectively. 5-year OS and 5-year net survival were 18.8% and 1.09, respectively. With a multivariate analysis, ECOG-PS 224, PNI less than 49.1, and endoscopic curability C2 were independent prognostic factors. When none of these factors were met, the 5-year OS rate was 90.4%, which is favorable. The conclusion of our study was the ER for EGC in late elderly patients may improve life expectancy and ER should be recommended in patients with a good ECOG-PS, PNI, and in whom ER is expected to be non-accuracy too. The strength of this study is large sample size with patients' background and regions information, high follow-up rate, and comparison with general Japanese population. The limitation of this study is single-center retrospective study, lack of the information about sarcopenia, and the proportion of patients with an unknown cause of death. In addition, this study didn't include a control group. For example, the groups of late elderly patients with EZC who didn't undergo ER. Further prospective trials are required for validation. Thank you for your kind attention.